Welcome to the Healthy Lifestyle Podcast, brought to you by Telehealth FX, your source for online GLP-1 weight loss and testosterone replacement therapy services. Visit telehealthfx.com to get medically guided access to weight loss peptides like semaglutide and tirzepatide delivered right to your home. That's telehealthfx.com. Now, here's your hosts.
I want to open today with a sentence I hear constantly, and I think it's one of the most quietly damaging things people believe about this whole topic. I don't think I qualify.
And usually said with this little apologetic shrug, like they've already decided, like they checked themselves out of the room before anybody else got a vote.
Right. And here's what makes it so frustrating. A huge number of the people saying that sentence are wrong. They do qualify. They've just confused two completely different questions that happen to use the same word.
Say more, because this is the whole episode.
Qualifying is two separate questions. Question 1, does the FDA-approved label fit you medically? Question 2, will your insurance company pay for it? Those are written by completely different people for completely different reasons. The label is written by the agency that approved the drug, based on who it was studied in. The insurance criteria are written by people whose job is to manage spending.
And mixing those two up is probably the single most common reason someone believes they don't qualify, when medically, they absolutely do.
That's it. That's the episode. So today we're going through both questions: what the actual medical criteria are, who's rolled out and why, how insurance fits in, what changed for people on Medicare literally 2 weeks ago, and how to walk into that conversation prepared instead of apologetic.
And the reminder we always give, which matters more on this episode than most. Nothing we say today is a diagnosis or medical advice. We're going to give you the general framework so you can have a smarter conversation, but only a licensed provider who evaluates you can tell you whether you personally qualify. We can tell you what questions to ask. We can't tell you your answer.
Fair. So let's start with question 1, the medical criteria. And it's simpler than most people think.
The FDA labeling for the medications approved specifically for chronic weight management uses a Tier 2 model. Tier 1, a body mass index of 30 or higher. That's it. If your BMI is 30 or above, you can qualify on that alone. No additional condition required.
Tier 1 is just a number, nothing else.
Nothing else. Tier 2 is where people get surprised. A BMI of 27 or higher if you also have at least one weight-related health condition. And the list of qualifying conditions is longer than most people expect. High blood pressure, type 2 diabetes, high cholesterol or dyslipidemia as it's called clinically, obstructive sleep apnea, established cardiovascular disease, fatty liver disease.
Let's sit on that for a second, because that Tier 2 number is the thing I most want listeners to hear. 27, not 40, not 35, 27 with one condition.
For a lot of people, a BMI of 27 doesn't look like what they picture when they picture qualifying. That's someone who might describe themselves as carrying 20 extra pounds. And if that person also has high blood pressure, which is enormously common, they meet the label criteria.
And how many people do you think are walking around with a BMI in the high 20s and blood pressure their doctor mentioned once and they forgot about?
Millions. Genuinely millions. And a meaningful number of them have told themselves they don't qualify.
Okay, one important distinction before we go further, because this trips up an unbelievable number of people and it costs them money. Not every one of these medications is approved for weight loss.
Yes, this is a mess, and it's not the patient's fault. The same molecule gets sold under different brand names for different approved uses. Semaglutide is sold as Wegovy for weight management and as Ozempic for type 2 diabetes. Tirzepatide is sold as Zepbound for weight management and as Mounjaro for type 2 diabetes.
Same drug, different name, different approved use.
And that distinction is exactly what your insurance company looks at. A plan might cover Ozempic for someone with diabetes and reject the same molecule for weight loss because the approved use doesn't match. So when people say Ozempic is a weight loss drug, they're using the wrong name for the thing they want, and sometimes that confusion shows up as a denial.
So if you're going into a conversation, the vocabulary matters. You're asking about the weight management approvals.
And one more note on the label. The weight management medications are approved for adults, with one exception. One of them is currently approved for adolescents ages 12 to 17 who meet obesity criteria. That's a genuinely different conversation with different considerations. And if that's your family, that's a pediatrician conversation, not a podcast conversation.
Well said. Now, let's do the other side of the coin. Who does not qualify? And this part is not negotiable.
These are what clinicians call absolute contraindications, conditions that rule out this class of medication regardless of your BMI or anything else. a personal or family history of medullary thyroid carcinoma, which is a specific and rare type of thyroid cancer, a syndrome called multiple endocrine neoplasia type 2. These are on the boxed warning of the label, which is the most serious warning the FDA issues based on findings in rodent studies.
Also known hypersensitivity to the medication or its ingredients.
And current pregnancy or breastfeeding. The safety data just isn't there, so it's not recommended. And there are others that require careful conversation rather than an automatic no. A history of pancreatitis, a history of an eating disorder which needs a thoughtful, individualized discussion with your provider before anything else happens.
And notice what all of those have in common. Every single one of them is discovered during a real medical evaluation, which is the argument we've been making for 3 episodes now. Supervision isn't red tape. Supervision is the thing that finds the reason you shouldn't take this.
The evaluation isn't the obstacle between you and the medication. The evaluation is the medicine.
All right, myth busting. Myth 1, the big one. I'm not heavy enough to qualify.
We just covered it, but it deserves the label of myth because it's so widespread. 27 with one condition, and if you're at 30, you qualify on the number alone. The picture in your head of who this is for is probably calibrated to the most dramatic before and after photos you've seen online. And that's not the criteria. That's marketing.
Myth 2. My insurance said no, so I don't qualify.
This is the one that makes me want to shake people lovingly. And it
Today's episode is brought to you by Telehealth FX, your source for online GLP-1 weight loss and testosterone replacement therapy services. Visit telehealthfx.com to get medically guided access to weight loss peptides like semaglutide and tirzepatide delivered right to your home. That's telehealthfx.com. Now back to the show.
Insurance denial is not a medical determination. It is a coverage determination. Those are different words on purpose. You can be perfectly unambiguously eligible under the FDA label and still get denied by a plan that has decided not to cover this category or that wants more paperwork first.
And denials get overturned.
Regularly. Reporting on prior authorization suggests appeals succeed at a meaningful rate when they're properly documented. That word documented is doing all the work in that sentence. An appeal with your BMI history, your diagnosed conditions, your prior weight loss attempts, and your provider's clinical reasoning is a completely different animal from a phone call where you say, but I really want it.
Which is another quiet argument for being in a supervised program. Your provider is building that documentation whether you ever need it or not.
Myth 3. BMI is the whole story.
And this one's interesting because here we're going to gently push back on the criteria themselves. BMI is a screening tool. It's height and weight, and that's all it is. It doesn't know the difference between muscle and fat. A very muscular person can land in the overweight range and be metabolically perfect. Meanwhile, someone with a normal BMI can carry a lot of visceral fat, the kind around your organs, and have real metabolic risk.
And there's meaningful variation across different ethnic backgrounds in terms of where metabolic risk actually starts, which BMI wasn't designed to capture.
So what do good clinicians do with that?
They use BMI as a starting point, not an ending point. Some use waist circumference as supporting evidence because it correlates with the kind of fat that actually drives metabolic risk. The general thresholds associated with elevated risk are around 40 inches for men and 35 inches for women. That's not on the FDA label, but it can strengthen the clinical picture, and it's information your provider may find useful.
So if you're borderline, that's a reason to have the conversation, not a reason to skip it.
Exactly. Borderline is not the same as no. Borderline means somebody with a license should look at the whole picture.
Okay, let's talk about what changed recently, because there's actual news here and it's fresh.
This is worth knowing if you or a parent is on Medicare. Historically, standard Medicare Part D did not cover these medications for weight loss specifically. That was a hard wall for a lot of older adults. As of July 1st of this year, 2026, so about 2 weeks ago, a new time-limited program launched that provides access for eligible enrollees at a substantially reduced monthly copay, running through the end of 2027.
And I want to be careful here, because we looked into this and the reporting on the exact eligibility criteria is genuinely inconsistent across sources.
It really is. Different outlets describe different combinations of BMI thresholds and qualifying conditions, which tells you it's new, it's evolving, and the details matter too much for us to guess at on a podcast.
So here's the honest version. If you're on Medicare or you have a parent who is, this door may have just opened for you, and it wasn't open a year ago. Call your plan and ask directly whether you're eligible under the new pathway. That's the move. Don't take our number for it because we're not going to give you one.
We'd rather tell you the door exists and let your plan tell you if your key fits.
One other thing worth knowing. Even if insurance is a dead end entirely, that doesn't automatically end the conversation. Manufacturers have direct pay options now, and telehealth programs bundle costs in ways we covered in our cost episode a couple weeks back. Insurance saying no is not the same as the door closing.
All right, practical segment. Someone's listening, they think they might qualify, they want to actually find out. What do they do?
Walk in with your numbers. Step 1, know your BMI. It's height and weight. There are free calculators everywhere. It takes 30 seconds. Step 2, and this is the one people skip, write down every weight-related diagnosis you have. not how you feel, what's actually in your chart. High blood pressure, prediabetes or diabetes, high cholesterol, sleep apnea, fatty liver, heart disease.
And people forget these constantly. Somebody got told their blood pressure was borderline 3 years ago and never thought about it again. That's potentially your tier 2 ticket sitting in a file.
Step 3, write down your weight history. What you've tried, what happened, where you were a year later. That's the documentation piece that matters for both the clinical conversation and any insurance appeal down the road.
And step 4, ask the right question. Not do I qualify, which is vague. Ask, do I meet the criteria for weight management medication? And if my insurance denies it, what are my options?
That second half of the question is what separates people who get treated from people who get discouraged.
And this is where we'll mention the folks who help make this show possible, because determining eligibility is literally the first thing they do. Telehealth FX starts with a real evaluation of your health history by a licensed provider, which is exactly the process we've been describing for the last 20 minutes. If you've been sitting on the I probably don't qualify assumption, that's a question you can just get answered rather than assume. Go to telehealthfx.com and find out instead of guessing.
Common mistakes. And these are all versions of the same one. Mistake 1, self-disqualifying. Deciding before anyone with a license has looked at you. That's the one this whole episode is about.
Mistake 2, treating an insurance denial as a verdict instead of a first round. Ask why you were denied. There's a reason code. Often it's a documentation gap, not a real ineligibility.
Mistake 3, going in without your numbers and having a vague conversation that goes nowhere.
And mistake 4, the opposite failure. Trying to work around the criteria. Finding a source that doesn't ask questions, or shading the truth on an intake form. Those contraindications we talked about are not bureaucratic hurdles. They're the reason the boxed warning exists. Getting around the screening isn't winning.
And the nuance we always honor. Qualifying doesn't mean you should. Some people meet every criterion and after a real conversation, decide that structured lifestyle change is the right first step for them.
Thanks for listening. Be sure to visit our sponsor, Telehealth FX, your source for online GLP-1 weight loss and testosterone replacement therapy services. Go to telehealthfx.com to get medically guided access to weight loss peptides like semaglutide and tirzepatide delivered right to your home. That's telehealthfx.com. See you next time.